and it's a great pleasure to introduce Professor Sparchez with this talk. He will give a talk about contrast and ultrasound and monitoring of interventions.
Okay, thank you very much. First of all, I want to thank EFSUMB for this kind invitation to present our results in this field of using contrast-enhanced ultrasound in abdominal intervention. You have seen from the presentation from Dr. Meloni, it's very important use in ablation. I will focus mainly on biopsy in abdominal lesions, and I will focus also in the drainage procedure. You already know the big role of contrast-enhanced ultrasound in diagnosing liver lesions, also pancreas and spleen lesions, but I want to present you the features of contrast ultrasound which may be helpful for interventions, because you all know that ultrasound is a very good method to guide interventions, but it has some limitation. In this field, CEUS may help us because it may display both vascularized and necrotic areas, and this is very important for biopsies, because we can sample a specimen from active part of the tumor, not the dead one, and it's also helpful in ablation. It helps us because we may detect lesions not seen by ultrasound, like isoechoic lesions in the liver or pancreas. CEUS may be used as real-time guidance or as pre-planning, because needles and catheters are seen also on the CEUS image. We may have intravenous use, like in a normal diagnosis CEUS, but also we can inject, as we will see, contrast agents through the needles or catheters. And the other advantage is real-time imaging, no radiation, and using in patients with renal impairment. So first of all, I will speak about percutaneous biopsy. Why we need an improvement? Because with all the innovation in ultrasound and the needles, the sensitivity of the percutaneous biopsy is around 90%. It's not more than usually the 90%. Why? Because we have some factors that lower the accuracy, like small lesions or poorly visualized lesions or invisible lesions in B-mode ultrasound, or large tumors with necrotic areas. So we have CEUS as optimization methods. We can use also navigation, but navigation is a little bit more complicated and time-consuming than to inject the CEUS and optimize the procedure. How can we do this? We have two main options. Either to do the interventions in real time, so we have the image, the contrast enhanced image usually is a split mode image. We have on the left or right side the quite normal image, and on the other half of the screen we have the contrast image. So we can give contrast, and to do the biopsy or the needle or the catheter insertion real time. Or the other option is to do a contrast study and to use the information obtained in this study in a further conventional US guidance procedure. So I will start with biopsies. Why to do this? Because we can take samples from active part to avoid necrosis. We can biopsy poorly or invisible lesions, or we may have some additional benefits. So have a look here on a patient with a pancreatic cancer, which was sent to us for a liver biopsy. But look here, the lesions are not seen in B-mode ultrasound. Meanwhile, in contrast, you see them very well in the late phase, and also you can insert a needle and take a sample from that lesion. Or for the lesions, for the metastasis, it's not very complicated because we have enough time to do the biopsy. For lesions that are seen only in arterial phase, like for example a hepatocellular carcinoma is not well seen, and if we inject contrast in arterial phase, we see the enhancement here, and we can put the needle inside the lesion and to sample a specimen. This technique, as you have seen, is also used for ablation if the lesion is not seen. But now, in this case, we have to hurry a little bit because we have not much time to till the arterial phase ends. So in this way, we can increase our accuracy because this was demonstrated for liver, cirrhotic liver, or also pancreas. What about large lesions? Here we see a case with a very large liver lesion, and it was sent for us to biopsy. If you put the needle inside the middle of the tumor, we may sample only necrotic specimen. But if you use the information obtained through this very nice contrast study, we can sample the specimen from an active enhancing part, so avoiding necrosis. So we could demonstrate a couple of years ago that using this technique, we are able to increase our sensitivity on percutaneous biopsy in liver tumors from 81% to 96%, so 15% of increase. And this is also valid for large lesions and also for lesions that are present in patients with chronic liver disease, especially liver cirrhosis, where here even more is more difficult to see some lesions. And here you see on this slide that we have an increase of almost 20% of accuracy and sensitivity for all the lesions, for larger lesions, or lesions, even 30% for lesions that are very have a poor conspicuity on B mode ultrasound. Which are the limits? Of course, if you have to do the biopsy in the short arterial phase, we have to hurry a little bit. We have to be skillful for that. But if you do before a CEUS study, we can focus on a certain region, and then we have time. Look, the quality of the image of the needle in the CEUS field is not as good as in a normal one. And here is depends on the quantity of contrast. It's not recommended to give too much contrast because the high intensity of the enhancement will mask the presence of a needle. So this could be possible indications besides these large and tumors invisible or poorly visible, residual or renascent tumoral areas after ablations, or cystic tumors with solid components, or portal vein thrombosis. What about complications? You know that biopsy is associated with some complication. Here is a case with a large hematoma in the liver after a liver biopsy, and you see that in this case we could demonstrate perfectly the lesion and also the fact that the bleeding stops, so we don't see contrast inside the lesion. In another case, also after a liver biopsy, we see the patient experiences pain. We see here something is wrong in the liver. And when we inject contrast, we see that actually is an active bleeding. Vessels here in that area was hit by the needle, and you see a very important bleeding which goes outside the liver. So it's very important to monitor this patient. The patient was sent for interventional radiology. What about other lesions? It was demonstrated that although there is not already a published paper, that for renal and adrenal tumors, here we have also not 100% sensitivity in diagnosis. We have an increase. And look here, a renal tumor, a large renal tumor with a lot of necrosis inside and some active parts on the periphery of the lesion. So we have to sample the specimen from there. Or another interesting case, it was sent to us. This is the first moment we saw that here is the tumor, but this is a cyst without enhancing. And in fact, the tumor is hypo-enhanced in arterial phase and is here. So we could sample a specimen from that part so we could demonstrate the presence of renal cell carcinoma. Also, a problem is with renal lymphoma, where you see these big kidneys. We don't know exactly where is the tumor and where is the normal parenchyma, and CEUS is helping us to guide the needle in the active parts of the tumor. For adrenal tumors is even more important because as you see here, a lot of tumors have important necrosis inside, and you see here a necrotic lesion, adrenal lesion with a lot of necrosis inside, and it's important to put the needle in an active part. You see here from that region we sampled it, so we could demonstrate the neoplasia in that case. Also, as complication is good, a patient 2 days after the renal biopsy had pain. We see that image, and after contrast injection, we see that there is actually a pseudoaneurysma. You see very well, and here the thrombosis of the pseudoaneurysma. It was only an active part, or we can also see a small bleeding inside a cyst that was treated with aspiration and ethanol injection. You see here, but the bleeding is not important. You see some droplets of contrast coming in. It's a venous bleeding, and the bleeding stopped. Regarding intraperitoneal tumors, also we could demonstrate a 15% of increase for retroperitoneal tumors, and almost 22% increase in sensitivity for intraperitoneal tumors. And here you have some examples: a large tumor, a non-Hodgkin lymphoma with necrosis in the middle. We put the needle in the margin where it's enhancing, and we had the diagnosis. And here, very interesting case. We saw there is a tumor who had an enhancing part, and it was an all mesenteric abscess with some inflammation remaining in this part. We saw there is maybe it's a tumor, but it was not. So also for this, so what about the guidelines? We have here the guidelines, and in respect with all what I have told you, we have recommendation from this kind of applications. There are some debated issues: when to use it, how relevant is in clinical practice. Recommendation to use clearly when the lesion is not seen or not well seen with ultrasound, then we probably use the CEUS guidance. We cannot do a pre-CEUS test. Or after an unsuccessful US guided biopsy due to necrosis or a targeting error, it's mandatory to use this technique. We don't know exactly in large lesion above which size it's mandatory to use this technique. Cost effectiveness analysis should be performed. In real life, in fact, the prevalence of, as it was published in this very nice study 2 years ago, the prevalence of the CEUS in the normal practice is low, only 22.6% in a multicentric Italian study. And you see here the indications are those I have discussed. What about the drainage procedures? We can use it both the intravenous use and also the intracavitary. We can use it for intracavitary. We mixed 0.1 ml or even more with 10 ml or more of saline, and we can inject this through a tube or a needle. And it's very important before doing a drainage of an abdominal collection to have a good treatment planning regarding the number, the size of the collection, the presence of fistula. And it's very important to identify details that may be responsible for a treatment failure, like communication with neighboring structures or anatomical details of abscess, so the presence of septa or areas without liquefaction. So let's have a look on a liver abscess. It's here. You see it. It's a liquid area. If you do a normal contrast study, we see very well the normal characteristic of the abscess. It's not enhancing in the center part. We have some septa and some small chambers at the periphery, and hyper enhancing around due to inflammation. But if we inject Sonoview through the tube that was put in that case, you see that there is an enhancement of the, but also you notice here there is the leakage from that part through bile duct. So that and very complex abscess with a lot of ramifications, and this may explain why if you put only a needle and extract the pus, it's not enough. You have to put a catheter and maybe to do also a sphincterotomy. For more complex lesions, you see here a very complex lesions with a lot of chambers and compartments. It's mandatory to do this, and in some cases it's also necessary to put additional catheters in other parts to ensure a complete drainage of the procedure. We have also lesions around the liver. Is a collection in the gallbladder fossa after cholecystectomy, which was not responding to a normal aspiration. And if we inject through the needle, we see that from that collection, the contrast agents go into the main, in the common bile duct. So there is clear a fistula. So the common bile duct was disturbed during the cholecystectomy. And this is I prefer using this kind of mode because we have also some B mode information and we can focus better on a specific area. Also, it was a case with abscess near operation or surgery for colon cancer. You see a collection with pus. We put a catheter. And but we have continuous accumulation of fluid inside, and then we inject contrast in that collection. And we see very well that we have the presence of the contrast agent inside the colon, so demonstrating the fistula. So there are some studies regarding these two studies only, which demonstrate a good placement success. And additional information obtained through this technique in 35 to 50 of cases, and is very helpful in interventional ultrasound because we can avoid Eric's procedure. Regarding CEUS cholangiography, you see it during percutaneous biliary drainage. We can inject also Sonoview and see we have a very good cholangiography which is comparable with the radiographic cholangiography. We see very well the intrahepatic and also the extrahepatic bile duct. We can see where is the catheter inside, and we can also demonstrate if you have a communication from the left to the biliary system. We can also depict a stenosis. It's very nice. You see here very tiny stenosis, and you see that there is a very good correlation between this image and the X-ray image regarding the dilation of the bile ducts and the stenosis. I will skip this because the time is running out. Also for assessing complication, you see here there was a dislodgement of the catheter from the biliary ducts. And if we inject Sonoview through this tube, you see the accumulation at the periphery of the liver, and this could be demonstrated also by X-ray. So we have some studies here more than for drainage of the abscess, and this technique is very good to diagnose the obstruction in respect of the level, degree, complete or incomplete, more than 96%, and even in some cases we can demonstrate the cause. As look here, it was a very interesting case. We inject through the catheter, and you see here a lot of biliary metastases, roundish into the bile ducts. So also for percutaneous nephrostomy is useful, especially in patients with non-dilated renal collecting system and there are some papers published in the last year. So my final slide is regarding the bleeding. We can detect bleeding from various organs like liver or spleen after biopsies, and moreover we can use this information to treat. And let's look on a patient which has an ablation but is the same as for biopsy. We see here a channel 10 minutes after the ablation, and when we inject contrast, we see an arterial bleeding from that point through the periphery, a small accumulation there. What we can do in this case to treat the bleeding, we can do interventional radiology to coil that vessel, but or we can do an ablation here to destroy that part of the tumor. We in this case we decided to go with a needle inside the tract, and we injected glue, polydocanol inside, and the tract was embolized, and after that we did again a contrast study, and the bleeding was stopped. So no more, we don't see anymore the vessel running out from the liver through the perihepatic area. So the bleeding has stopped and the patient was well. It lasted only 10 minutes to do this. So finally, to conclude, CEUS is an excellent tool in performing abdominal echo-guided intervention. We can use this for planning, performing, and also assessment of success and complication, and in some cases also to treat complication. And after surgery, after hepatobiliary and pancreatic surgery, when we need very often some drainage procedure, it's very important to diagnose this complication and to treat. Thank you very much for your attention.
So, Professor Sparchez, very nice talk, very interesting cases. We already have a couple of questions from the audience. So when I should start with the first one asked us, how are you selected patient for using ultrasound contrast in cases of invisible METs or HCC carcinoma in B mode after CT or only during your ultrasound examination?
So usually we have the information from CT or MRI. We know from that examination where is that lesion located, and we focus with contrast on that part. If it's a metastasis, it's not a problem because we have enough time to detect it in parenchymal phase. If it's an HCC without washout, then it's more difficult because we don't have enough time to see all that region. And if you are not successful after the first attempt, we can re-inject another dose of Sonoview, and in order to detect that lesion. Or in cases where we cannot do this, we use also the fusion to see better where is the lesion located. But usually with contrast, we are able to detect almost all cases, almost lesions in the liver.
Okay, there was another question. What is the indication for treatment kidney cyst? You mentioned aspiration ethanol instillation.
Yes, this was the classical treatment. We are using more and more polydocanol injection in the kidney cyst, but we more problematic, and is a debate when to do this. It is usually performed in patients with symptoms and large cysts, so above, let's say, 7-8 centimeters with symptoms. Otherwise, if the cyst is small, you can leave it, and it's a normal cyst, not a tumor, you can leave it there. It's not, you have no reason to treat it.
Okay. In the time, due to the time, I think we have to stay in time. I would like to thank you for both speakers for the excellent talk. I also like to thank you to the EFSUMB that support us to share our knowledge with our friends. And in case if you have not any more questions, I'm very keen on the next webinar. coordinated by the EFSUMB.
Bye.
Thanks
Bye.
and have a good
Thank you,
evening.
bye.
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 Thank you.
Bye.
Bye.